Thank you, Vas, and I'll pick up the story from here, talking about how faricimab can provide extended durability. We're going to start with this heat map of Yosemite and Rhine pooled data at the patient level. And what I like about this heat map is that it really reflects how I would treat my patients. Green is the Q4 week interval. We see everybody's getting loading doses. I'm a big believer in loading doses in DME. While we see that some people never get off the 4-week interval, and we know that we all have some of those really tough patients, what you see for the remainder of the graph is some of these straight arrows that go from Q4 to 8 to 12 to 16 weeks. But by the end of 2 years, we see that we have a very high percentage of patients in the clinical trials on Q16-week and Q12-week intervals. And they got there with disease control. And that's what I like because it kind of mirrors the way I think all of us like to practice. And another way to look at this is if you look at the pie at 52 weeks in the pink area, which is the Q16-week group, it's at about 52%. But by week 96, it's increasing. We're not pulling it back. We know that we've gotten patients there in the first year safely, and that proportion of patients actually extends in the second year. So now here's a question. What are the efficacy outcomes of patients who actually end the study on a Q12-week or Q16-week dosing interval? And for the very first time, this data is being presented at EURETINA by Marta Figueroa. I'm just sharing one slide from her presentation. And it breaks out the Q16-week group in the pink line. And those are the good actors. We really expect them to do well. But the purple line is the Q12-week group, and we see that they do every bit as well as the overall group all the way out to week 100. So these patients in the Q12-week and the Q16-week groups are doing well when we look at visual acuity, and they're doing well when we look at anatomy. So we can now ask the question, for those patients who completed a Q16-week cycle, how many of them would have met criteria for potentially extending to Q20 weeks, which is not on label, but it's a hypothetical situation that we can apply to this clinical trial data. And the answer is more than half. 56% of patients who are at Q16 weeks could have extended to Q20 weeks. So in these slides so far, I've shown you clinical trial data, some post-hoc analyses. Now let's take a look at some real patients. And for this year, I've been visiting professor at Roche. And so I've been traveling around the world, meeting physicians, talking to colleagues about how they're incorporating faricimab into the treatment of their patients with DME. And I'm going to share with you some of those cases. And the first one comes from Switzerland, from doctors Olja and Ambersen. And this is a 75-year-old woman who was originally diagnosed with DME in 2019. She gets 24 aflibercept injections, mostly at a Q4-week interval, because the intraretinal fluid never goes away. And you see it on that first panel on the left-hand side. There's a little bit of intraretinal fluid. So they were asking themselves, is this degenerative cystic change or is this active leakage? And rather than doing Vas's 2-week test, they decided to go out to Q8 weeks with their interval, and you see a worsening of the intraretinal fluid. So that's pretty much telling them that this is active exudative fluid. So now we're going to use that as our baseline for the switch, and this patient gets switched to faricimab. And in this clinic, faricimab number 1 was given, faricimab number 2 was given 4 weeks later, but no OCT image was taken. And because this is a real-world case, the patient misses an appointment. So that second image is looking after faricimab number 2 at the 8-week interval, and you see a near resolution of that intraretinal fluid. But then they give the patient a pep talk, better compliance. They give faricimab number 3. They see the patient back 4 weeks later. They give faricimab number 4. And then by the time you get to the far right panel, the intraretinal fluid is completely gone, and there's even some attenuation of the hyperreflective foci that we just heard about. And the vision is excellent at 20/25, so the patient is extended to Q8 weeks. 8 weeks after faricimab number 5, the patient is given number 6 and extended to Q12 weeks. And then when faricimab number 7 is given, the patient is extended to Q16 weeks. So here we have a switch patient who was able to achieve complete resolution of the intraretinal fluid after being stymied and never getting beyond a dry Q8-week interval. And within 7 injections, this eye was extended out to Q16 weeks. So that's the first case that I wanted to share with you. The second one comes from my friend Viral Sheth in Chicago. He has a 45-year-old woman who was diagnosed with DME in October of 2021, and the patient declined therapy. This is a real-world case and gets lost to follow-up for 10 months, and we all know the natural history of this disease. By the time she comes back, her vision's 20/80, and you see the CST is over 625. And Viral gives the first faricimab injection. Now, this is a little bit different than Paul's experience. It's a little bit more what I expect from these very severe cases, is that it's a slower response, but as long as you're making incremental improvements. And I see the CST here going from 478 to 400 to 369 as we move from left to right. And in these very difficult cases, this is what I hope to see. And notice what's also happening with the vision from 2060 to 2040. Big believer in loading doses. This patient is actually doing very well. Now, by the time we give faricimab number 5, the vision's 20/25 and the CST is 284. But we're 8 weeks after faricimab number 4. So the 5th dose is given, the interval is kept. Viral says, come back in 8 weeks. The CST is better, the vision's still 20/25, but he doesn't give an injection, and he says follow up in 8 weeks. That means we are now on a 16-week interval, and the anatomy continues to improve with faricimab given every 16 weeks, and this patient actually ended up getting faricimab number 7 and is being maintained on a Q16-week interval. So what we see here is very, very fast extension, even with a little bit of residual intraretinal fluid, and the patient continues to do very well. Here's the final case from Michael Singer. He might even be here today. Thank you, Michael, for this case. It's a 74-year-old white male diagnosed with DME in September of 2020. And if we look at the treatment history on the right, it's about a year of 9 injections of an off-label anti-VEGF therapy, somewhere between Q4 week and Q8 weeks, followed by a year of about 8 aflibercept injections, again, usually at an interval of Q4 weeks to Q8 weeks. And then you'll see what happens when the patient is switched to faricimab. So in Michael's OCTs in his office, he always produces 2. What you see on the left-hand side is from the same day. One's a vertical cut through the macula, the other one is a horizontal cut through the macula. We see the vision is 20/60 at baseline, the CST is 356, and this is the point, this is the beginning of the story where one off-label anti-VEGF injection is given. On the right-hand side, we see the results after a year of this, 9 total injections. So this is when Michael says, you know, the vision's better, but I'm not happy with the anatomy, and switches to aflibercept. What we see here on the left-hand panel is 1 year after 8 aflibercept injections. Here, this is a Q12-week interval. Again, the vision is stable, but we still see some intraretinal fluid. Now, you might say, well, this is okay, there's on a 12-week interval, but I have yet to meet a patient who doesn't want fewer injections. So this patient is switched to faricimab and is seen at the same interval. The vision's now 20/25, the anatomy looks about the same. Michael gives the second faricimab injection and extends the patient out to Q16 weeks, even in the face of some intraretinal fluid that persists. And what we see is that the vision goes to 20/20, the anatomy continues to improve, and Michael goes out to a Q20-week interval. And in the final images that we have on this patient, the vision's 20/20, the anatomy's never looked better, and right now this patient is being maintained on faricimab at a Q20-week interval. So, in summary, we have some pretty good real-world extension cases, and I'm happy to take any questions.
Thank you, Nancy. Very interesting cases, a lot of questions and things that we can ask. I have one question for you, is when we are striving to extend the interval, in one of the cases, the interval was extended when there was some fluid still in the retina. This is something you recommend, or when?
Yeah, I noticed that too. What I think it boils down to is disease control. Like the comfort that you have the disease under control, that you believe in the durability of dual inhibition. And interestingly, it was present in 2 of these cases. The last 2 cases were extended with small amounts of fluid. Now, in the clinical trials, one of them would have been extended because they met CST requirements. The other one exceeded the CST requirement. But in real life, I think disease control is really what matters, and sometimes we also have to manage patients. But both cases did very well.
And on the same kind of discussion, how often it happens that the interval is extended and then it's necessary to shorten it a lot because there is some fluid?
Well, we certainly saw that in the clinical trial data patient-level heat map, that sometimes you have to pull back the interval. I can't tell you exactly how much it happens in the real world, but even if you have to contract, in my own experience, I might contract it, keep someone on that interval for 3, 4 injections, and then try to extend again. So I think over time, it's still possible to go back and extend. I don't ever commit someone to that restricted interval.
Thank you. And another question about the extension. So in one case, in some cases, you can extend to Q20. So this, to build on the disease modification, and why not to stop? Maybe they don't need, it's even no injection at all.
Yeah, no, that's a really good question. Is this someone who still needs injections? Are we seeing disease modification where they don't need injections? I will have that conversation with patients. Some of them prefer to get their shot and then not see me again for 20 weeks. But some of them want to be monitored, and I would never stop seeing the patient, and I would monitor them closely. But it's all part of individualizing the treatment.
Thank you. Can you join us? Thank you very much.